next topic. And I
All
am really
right.
interested in how to integrate this DRL stuff to my daily work and how can I comment or use that DRL and tell my technologists what is the next step that you should do. Please.
All right. That's a great setup. Thank you. Thank you, Tanya. Okay. So there we go. My next topic is really just an extension of the first talk. How do we establish? Now, how do we use these DRLs? And the values that Dr. Panrutai discussed and demonstrated, I have several examples from her slide deck, and we're going to talk kind of broadly and globally. We're not going to really get into the detail of all of her data, but I have some suggestions and some ideas as I've read through the data. So once again, my talk is based on ICRP publication 135. So I hope to summarize the usage of DRLs that document discusses and details. So using DRLs. For the first, DRLs are used as a practical tool. So we're meant to do this. They're established for diagnostic radiology, nuclear medicine, and our interventional labs, both IR and cath lab. And the goal here is for achieving acceptable image quality or adequate diagnostic information consistent with medical imaging task. This is the overall goal. The goal is not to get the lowest dose or the highest dose, which would be obviously crazy. But the goal is not just to go lower, lower, and lower. The goal here is to have acceptable image quality to provide the proper diagnostic confidence to our radiologists. DRLs are used then to help manage the radiation dose so that we get the proper image quality and we have the ability to answer the clinical diagnostic task. So the objective of a DRL is to help avoid delivering excess radiation that does not contribute to a clinical task. This is accomplished by comparing your local values at your local hospital or clinic to these new national values that Dr. Panrutai and her team have established. So ultimately, excessive dose does not improve diagnostic confidence. We've demonstrated this for years and years and years in the academic literature. And so all that is risk. When remember, we talked about the benefit to risk ratio. If the benefit to risk ratio is off, then it's not technically medically sound for us to continue using that imaging technique. So we've talked about this quite a bit, but you're going to hear me say this many times over the next several weeks. What are the DRLs and what are they not? So let's start with what they are not first. DRLs are not to be an individual patient. In other words, if you're a radiologist and you just dictated a non-contrast brain and the value was the volume CTDI, let's say it was 45. And you should not pick up Dr. Panrutai's document and go, oh, the national TI level is 40. And then you would then think, oh, this was too high a dose. This was a bad study. So that is not how we apply DRLs. DRLs are not to be applied to individual patients. They are not to be used as a limit for patient examination. In other words, you don't go turn all your protocols down so that for example, volume CTDI is less than the national DRL. We're going to talk about that, but that's not what they're meant to do. They're not dose limits. And so if a patient gets a value that's higher than the DRL, that's not necessarily a bad thing. It's something that we just need to talk about. They're not to be used as punitive or regulatory purposes. So we're not going to close down a hospital just because their values are higher than the national DRL. It does not ensure diagnostic confidence. So this is interesting. Obviously, if it's a high dose, it's probably a good image quality, right? Right? Well, we don't know that. Just because the value is higher than the national DRL, the 75th percentile, it does not necessarily mean that there is more diagnostic confidence. It does not necessarily mean that it's got better image quality. And it does not necessarily mean that the acquisition technique was good or bad. It's simply saying that the value is higher than the threshold. I know that seems simple, and I'll explain why that's a good thing. But when we establish DRLs, it's quite literally just a line in the sand. It's just a simple threshold, and it gives us a reason to start to ask ourselves, why are we on this side of the DRL versus this side? And we'll give some examples of that later. So what is a DRL? It establishes the context to compare examination doses, and we can compare it, as we talked about, locally, regionally, nationally, and maybe even internationally. They help to identify trends. This is one of the most important things. And so we can, once we understand these trends, if one hospital is too high or higher than the DRL, if it's one hospital is lower, or if one hospital has a bunch of CT protocols that all are below the DRL, except for, say, the non-contrast brain, which is higher, it allows us to see a trend. And then we can do what's called a root cause analysis, an RCA, so we can identify why that one protocol may be different than the others. And it helps us to understand what we may consider at that local hospital too low and too high. And so it's giving us a way to just kind of start to investigate and ask these questions. All right, so the purpose of a DRL is to identify facilities where dose levels are higher than the 75th percentile of the national median, representing a need for optimization. National median values, or these AD values, the achievable dose values, provide an additional benchmark to better identify areas for ongoing optimization. The attempt to modify patient dose and image quality to bring an institute's dose levels below the AD represents a good practice. So the ICRP 135 indicates the 75th percentile is one value, the 50th percentile or the AD is another value, and that the ultimate goal of getting below the 50th percentile is potentially a good practice. Now we'll talk about not why we don't take all of our protocols and immediately just drop their doses. But if you have one protocol that was higher than the 75th percentile, maybe it's a little lower now than the 75th percentile. The question is, do we continue to optimize below the 50th, or are we happy? And there's always reasons for us to stop or to continue to go forward. So now I want to kind of shift. I know Dr. Panrutai gave a great talk. I imagine every word she said was amazing and wonderful. Unfortunately, I didn't quite understand all of them. And so she was kind enough to share this data with me beforehand. And so I had a chance to read through it and I looked at it. And I wanted just to point out a few things. So you received we had my talk before, my first talk went. And we talked about all of the things that the ICRP, or the International Community suggests that we do first. And it just should be commended that Dr. Panrutai and her team have basically checked off all of those boxes. So for example, they started with radiography, they started with projection radiography and dental, and they started with a single dose metric. And those are usually the highest frequency, and within radiography, they're going to be kind of the higher doses, like an abdomen single or two-phase, or not phase, excuse me, view. And so they started collecting the data that was easy, high frequency. And now, when you fast forward to 2021, they're circling back around for their second cycle, and they're including a new calculation or a new dose metric, which is CAP. And remember, we talked about how oftentimes it's suggested that we don't just collect one, but we collect multiple metrics, which gives us ability to branch out and collect more data from even more hospitals that may not have just the ability to give you or report one metric. So she talked quite a bit about dental and CT. She demonstrated that they collected data for the 8 most common protocols, and that was back in 2018. Now fast forward, they then the next year started collecting more data. So as they became more comfortable with one set of metrics and protocols, they then added and expanded. And so this is a classic example of starting in one and continuing to increase and grow per modality. Obviously, there's IR and the cath lab. So they got interventional and digital mammography, and then nuclear medicine, as she discussed. Now, there's obviously some challenges with nuclear medicine being at a smaller, more, I guess, quote unquote, subspecialty in Thailand. But that doesn't necessarily mean we can exclude it. And so I think that's very, it's commendable that they have been able to collect the data that they could, and they were still able to calculate their dose distributions. So the other thing we talked about is the different organizations and the way to approach collecting and calculating DRLs. We talked about the high level government control down all the way to the individual clinic. And that's exactly kind of what they did. They started at the bottom and they've been working their way up. They started with just local hospitals, medical schools or academic schools. And they have usually the ability to, because they have more staff, they have, they may have medical physicists, technologists, and the radiologists, all of which can work as a team. And so they were they began as the first kind of soldiers in this battle. And they were able to go out and deploy the initial structure on how to collect this. And as they have established that at local institutions, they've now turned it over to more of a larger professional organization that will include more people at a more national level. And then what is planned as in 2021 is to turn this over to OAP, or the Office of Atomic Peace. Forgive me, that was the acronym I couldn't remember. I kept getting my letters backwards. The Office of Atomic Peace. And so the OAP will now be the one that'll spearhead this. And so that just demonstrated the proper lower to higher as they work towards having, and I know from the very beginning, Jiraporn talked about this in her talk last time and many years ago back in 2019 when I was there, how all of this started with the recognition at the government level, at the Ministry of Health, recognizing and needing all of this. So the government understood it. They gave their blessing to move forward, and then a small group figured it out and has eventually grown it back up. And so now you see the government being in a position to take and to go forward with this. So now that they have collected 4 years worth of data, they are from 2017 to 2020 and starting into 2021, they're moving on to their second phase, moving from manual data collection, which is what's been happening, to software collection. And so I know initially with several of these academic institutions, they did have electronic data collection, but it was localized to just a few hospitals. And so now moving forward with the help of the IAEA, the goal is to get this same software distributed more broadly, more globally throughout Thailand, so that we can speed up the process of data collection for DRLs for the next cycle, the next 3 to 5 year cycle. All right, so now that Thailand has established national DRL values for select examinations and procedures, these values can be published and will be published so that local hospitals and radiology and interventional clinics can compare their data with the national DRL values. And so Dr. Panrutai went through and she demonstrated some data for the variety of different modalities that they have collected values. So local hospitals will now be able to look at these values, the median values here, the 75th percentile, and they're going to be able to calculate their local median value and compare that to the Thai DRL, the 75th percentile. So the next big step is, now that we have these tables, we have these plots of DRLs, we go back to to all the very individual local hospitals, and they will have a template to work with. They can go in and they can look at their chest PA or their L spines or their skulls. and they can go in and they can collect data. Now, we talked about how it's nice if they could collect a minimum of 20 to 30 patients for radiography. It would be better if they could do this collection for multiple different rooms. If it's a larger hospital, maybe they have 10 or 20 x-ray rooms. And so they can start to collect specific patient data in each of these examinations, and that hospital will calculate the median value. And that median value will be compared to the 75th percentile or the DRL. Now, they will not do this as an individual patient. In other words, you see here now that they're collecting a population of data. So it's not, once again, the radiologist in the reading room looking at each patient as they are read and then comparing each patient's data to the DRL. But instead, what they're doing is they're taking a population of data, summarizing it, creating one value, a median, and that median value then is compared to the national DRL. So I kind of answered this out of sequence, but so how many patients should each local hospitals look to analyze or collect? There is no set number. There is the minimum of about 20 to 30. As I mentioned, ideally you'll get more as long as they can. But how much, when do you stop? Well, what you can do is you need to look at the spread of your data. You need to look at, so if you collect, let's say 100 patients or 200 patients. So when you take that data, you'll have your distribution and you'll be able to look at its first quartile, its second or the median, and the third quartile, obviously the mins and the maxes. And you can see very quickly if your data for the chest PA at your local hospital has a very wide range or a narrow distribution. If it's a narrow distribution, if you keep adding more, 200, 300, 400, 500, that distribution might move a little, but it's going to probably stay the same. What that means is your data is fairly well, it doesn't have a very wide range. Now, if you collect 100 patients and your data has very large extremes, you should probably do your best to collect more data to see if that changes the overall distribution. And so maybe if you collected that first 100 patients, because you're randomly selecting these 100 patients, and you may just accidentally, in that random nature, have picked a few more larger patients than maybe smaller. So your distribution may be broader. And so that's why if you look at your data and you watch it as you collect, maybe 100, 200, 300, you may find that eventually there's a diminishing return in the distribution of your data. So no set number, but the data will help you understand when you just don't need to go more. All right. When the local hospitals are collecting their data, though, they need to only collect data for very specific patient range, whatever the weight category was or the age category was that was used to calculate these numbers. So let's just say it was 70 kilograms, plus or minus 10 kilograms. I don't know. But whatever that value is, that's the value the local hospital should accept. The local hospital should not accept a 10 or a 20 kilo patient into that distribution, because then it makes the numbers non-comparable. And obviously, in this case, this is a digital system. And so they need to, and I know Dr. Pendertai shared digital and plain film. And so you need to make that basic separation of categories. If the local hospital, create multiple categories, but they don't match with the national categories, then you can't really compare your data. And so now that the national DRLs have been established, we have a template. And so we're just going to use that template. So in this case, we're going to find these examinations in this technology, and we're going to do it for this specific patient population, whatever that patient weight or age group was. So let's go through a scenario here. You are a local hospital. You just received this in the mail. You now are looking at your data. So you've gone out and you've collected a variety of values. So let's start with the chest PA. And let's assume you are a hospital, and your value is somewhere at, let's say, 4 milligray. It's one of these high values right here. So your value is greater than the Thai DRL of 0.31 milligray. So first of all, quick reminder, DR values are not dose levels. Therefore, this value that you just collected, you should not immediately just go and say, oh, I'll just turn down my MA, or I'll go turn down my KV. So my dose value would be more commensurate to or equivalent to the DRL. That's not what this is meant to do. You're not to just go match the value. What you need to do is investigate. So ICRP 135, the report, says if the value, your measured median value, or I should say calculated median value is greater than the national DRL, that should start the process for an investigation. Now, if you value like this one, this 4.32, this max value, if that was your hospital, you should probably start this investigation now with undue delay, because your value is very high, much higher than national DRL. And so there should be a sense of urgency to understand why that value is. And once you've investigated, you need to decide upon a corrective action. Now, we'll talk about different corrective actions, but there is the potential. Your value, here's the DRL, your value is higher than the DRL, and there is the potential that after you've investigated, you've determined that there is a clinical need for that protocol or that examination to remain at that dose point. And if that is your clinical consideration, then that is fine. You consider that. You go forward with that. There is obviously a clinical reason for that. So the benefit to risk ratio still is the benefit. Now, if there is no reason clinically that the images are required, these patients are required with an entrance skin dose of 4.32 milligray, then the risk to benefit ratio is out of balance. And so we need to now create a way to reduce that. So who should be on this investigation team? Well, it should have key radiologists or interventionalists, if we're talking IR cath lab. You need to have key individuals that are experts in this area. And you need to have your lead technologist or technologist, the person that is in charge of the clinic over, say, planar radiography or CT or nuke medicine, whatever. You need the lead technologist. And if you are able to have a medical physicist at your hospital or someone that's in the region, you should have a medical physicist part of that team. What is included in the investigation? First, we're going to ask ourselves, is this protocol, the appropriateness of the protocol, how is it being ordered? Is it being used properly? So if you're ordering a chest PA, an upright 2-view chest PA, is it being ordered for the proper clinical task? Or is it just one of those things that the patient walks through the door, so they just give them a chest PA, a chest radiograph for no other clinical reasons? So if you determine that the orders are appropriate, then the question is, how does the equipment work? Is the equipment working properly? Is it working per the specifications of the vendor? So let's say you have a Philips digital radiograph room, and they're going to have their specifications. They're going to have their field service engineers. You may ask them to review the machine and make sure when you're dialing in 10 MA and 70 kV and you're pulling the trigger, that's exactly what's coming out of the X-ray tube, because there's sometimes those things don't work. So you can have field service engineers and the medical physicist make some measurements. Now, if the machine's working properly, next step is the acquisition technique set up properly? If you're doing a chest radiograph and it's a common average sized Thai patient, And they're going to be somewhere in the 110, 120 kV range. Well, if you go in and you check, and what happens if the kV's been turned down too low? Let's say it's 70 or 90 or whatever. And someone has compensated because the contrast doesn't look good by turning the MA up really high, thinking that they can improve the quality of the image. In this case, the acquisition technique factors are out of balance. And so you need to ask yourself, do you have the right technique factors? And then finally, not finally, but you should ask yourself, okay, if my dose level is at 4, it's a entrance skin air kerma of 4, what does the image quality look like? Most likely the image quality, the higher the dose, the image quality is usually pretty clean. It's going to be very low image noise. In this case, where the doses are so high, I would actually think the image quality is probably not that good. You're probably burning out the lung field. You're probably clipping some of the anatomy. And so you're probably losing some detail. At extremely high doses in digital imaging is actually not good. So looking at the image quality will help you understand what you need to do to adjust the dose. Operator skill. And this is why it's really important to include usually the manager or the lead technologist. Is it that when you do an assessment of these chest radiographs, maybe it's the fact that either the technologists weren't properly trained on that one piece of equipment. So you have 10 X-ray rooms, and one X-ray room, the doses are super high. Maybe you have all Philips scanners and one GE scanner. And so people just aren't familiar, for example, with the GE scanner. I use that as a simple example. And so make sure the operator skill set is right. And then ultimately, for example, in a chest radiograph or like a CT scan or whatnot, are they setting their fields and their collimations properly? Because that can also affect dose. So maybe they know how to use the machines, but they're not being really good in the way they're doing all the things they've been trained at school. And then procedure complexity. Now, this tends to be more for interventional procedures. So this is really not probably one of the things you're going to ask a question about in X-ray or CT, because the complexity of those imaging techniques pretty much are all the same. Now, you might be doing a sunrise knee exam, so you're trying to image right through the patella, and that might require adjusting the way the X-ray, the digital plate is held at the knee. And so sometimes you might have to pull the trigger once or twice to get the right angle. So there is some complexity in it, don't get me wrong. But when I say complexity, we're usually talking interventional. So what causes variability, or what causes a complex procedure to be highly variable? Well, obviously, you're going to have body habitus, large patients versus small patients, that creates variability. Anatomical variation. I imagine most cardiologists would probably be perfectly happy if everyone's heart was the same and all of the vessels that went into the heart were exactly in the same location and they had the exact same contours and the exact same twists. It would just make their job real easy. But the complexity of our vascular system and the uniqueness of it, really, that adds a lot of variability. And then, of course, acquisition technique factors. So fluoro is inherently going to be difficult because based on the size of the patient, the system may use a higher or lower kV. It may use a different filter in the beam. Obviously, the MA is going to change just because of the auto brightness control in the image. So all of this, and of course, for example, forgive me, pathology. I mean, you may be working on a highly complex cardiac procedure. You might be implanting a pacemaker. I know, for example, my mother went in a couple of months ago and she got a pacemaker installed, and it took, I think, an extra 3 or 4 hours more than what they had anticipated to install it because of the way some of her arteries, coronary arteries, all the I think it was the one of her coronary arteries, how it was situated, and they were trying to get the lead into it, and it took them forever because her arteries were just not twisted, but they had just kind of a different angle to it. And so the pathology of how complex the procedure is can affect the variability. So all of that said, what do we do about these complex procedures, and how do we take into account the complexity and the variability when we calculate and then compare our DRLs? Well, the IAEA came out with their safety report number 59, and they established what they call a complexity index, or CI. And this is a way for them to take the dose values, for example, air kerma or CAP in an interventional procedure, and to normalize that data. So a simple, non-complex study may have one dose value, and a very complex, very highly variable procedure may have another one. But using these CIs, or these complex indexes, you can now normalize the data so all of the values will make more sense. So you can calculate your national DRL and compare it to all of these procedures, be they simple or complex. And so how do you do that? Well, that's several hundred pages of, it's really not that complex, but basically they go through step by step on how you take your national data that you've collected to establish DRLs and, for example, the cath lab. And it goes through step by step on how you set your graphs, how you do your calculations, your correlations, how you set your values, your stratify and set up what would be a non-complex versus a complex. And then ultimately it just walks you through that entire process. So it's actually, I read this document this morning. It was several hundred pages. So it was, or at least it was 100 pages or more. I can't remember. It was pretty long. And so I realized I didn't have enough time in this presentation to go through this entire process. But it's a good read. It makes sense. Like I said, it's a very straightforward step-by-step process. All right. So that's what happens if you're above the TIE. If you're a hospital that's above the national TIE DRL, you start an investigation, you figure out what it is with that team, you come to a conclusion, and then you make an action plan. Now, what happens if you're really much, much lower than the national TIE DRL? So let's say, for example, you're this hospital, and you've looked at your median value, your population for your chest PA, and the median value is 0.03 milligray. Well, the same process happens. You investigate the system. Now, in this case, really what we're asking ourselves is, okay, the dose is much, much lower than the DRL. So we probably should ask ourselves, is the image quality sufficient for the diagnostic task at hand? And once again, after you've investigated, you've established corrective actions. And we ask, the ICRP asks that once you've done this, you need to go back and follow up. So it's not good enough just to say, okay, all right, the dose maybe was too low, so we're going to increase the dose to make sure the image quality is better, and then just walk away from it and leave it for 3 to 5 years. The reality is you've made now a correction. You have now optimized this image a little. So let's follow up. Make sure that that optimization actually was appropriate. It actually solved the problem, and that everyone involved to create that correction action to solve that problem, they are consistent in applying that. And so there's always a time where it takes just to get that optimization to kind of stick and to take effect and to actually make a meaningful correction in the overall data. So it's going to take a while. You may wait 2 or 3, 4 months, and then you go back and you resample your population. And then did your value, if it needed to go down, or if it needed to go up, did it go up? All right. And this is, of course, very, very much important. This whole concept of follow-up and retesting is very important if you, in once you got the DRLs shortly thereafter, I don't know, a month or two, you end up replacing one or two of your x-ray rooms. And now you have newer technology mixed in with old technology. You need to do this whole investigative process to make sure the dose and image quality is optimized for both the new technology and the old technology. And then one of the things that the ICRP 135 report recommends is that you obviously establish a QA process, a quality assurance process. So people like medical physicists that will come in and do annual or some type of testing, be it quarterly, semi-annual, or annual testing. They may work in conjunction with technologists, but you have a group or a team that establishes a quality assurance program. And then as they go through this quality assurance program, they're going to be testing various things: machine output, spatial resolution, is there proper contrast in the image? They have their list of things they're testing. But one of the things that you should add to that list is, once they've acquired the dose output, they should also do a quick survey of the patients being imaged on that machine and ask themselves, where do they fall? How do they compare to the national DRL? So using DRL values as part of as one step or one part of the QA process that is used in that local hospital. All right, the third option here. So we've just looked at the extremes. What happens if your median dose is much higher than the national TI DRL, or much, much lower? But what happens if it's actually lower than the 75th percentile, but it's somewhere below the 75th percentile, but it's not all the way at the extreme low? What do we do? Well, I guess you probably figured it out by this point. You got to investigate. So the question is my value, just because it's below the 75th percentile, is it appropriate? Is it optimized? The answer is we don't know. Remember, a DRL value does not define a limit or a point of optimization. So the values on one side are not optimized, the values on the other side are optimized. That is not what a national DRL does. So you need to actually investigate. If here's your 75th percentile and you're just a little below it, or if you're a lot below it, is there reason for you to make any kind of modifications? So you investigate. Now that we're below the national DRL, one can say that the primary focus should be on appropriate image quality. So in the case of this hospital that had a median value of 4.3 milligray, which is much, much higher than 0.31, their primary focus probably should be on how we get the dose lower. But now that they're closer to and below the DRL, now the question is there sufficient image quality to further reduce the dose? And there may be. If there is sufficient image quality, then yes, the next step could be to reduce the dose some more. If the dose that's below the national DRL produces a certain level of image quality that is deemed sufficient or important, critical, or necessary for a diagnostic task, then the answer is no, you do not need to reduce the dose, or you shouldn't reduce the dose. Now, there will come a point after several years, as we mentioned, that national DRL value is going to go lower, just by sheer nature of everyone going through this process of investigating and optimizing their protocols. So if here's the national DRL, and if you're just a little below it, and you say, okay, that's fine, that's sufficient, we don't really want to do anything, we're not going to change the dose value, what happens when the national DRL slides the other way? And now you're on the other side, you're on the high side of, or you're above the national DRL. Well, there will come a point where you'll have a chance to then reassess. Now that time has gone on, now that we have been operating these many years at this dose point, do we still need that do we still need the image quality at that dose level? Or is it time now to say we could probably do with less. Ultimately, that's a question that has to be answered by the team: radiologist, technologist, medical physicist. There may be some protocols that will always require maybe a little extra dose. Now, if the national DRL is coming down, that means that 75% of or less, or somewhere is up to 75% of all the hospitals in Thailand can do the same task for lower dose. And so that's why you should ask yourself, is there really a reason why we have to do it above that? Oftentimes the answer is probably not. You just need a little bit extra push to move your practice towards a little lower dose and to do what it takes to, do the training, do the teaching, to get the help, so that nothing changes on the diagnostic confidence, nothing changes on the overall clinical outcome, but yet you can do it at a slightly lower dose. All right, so that is, it's a very basic step, and the answer was the same at every level of analysis: investigate, optimize if necessary. And so wherever you fall on that continuum, you need to consider that. So I want to shift gears just a little bit. So Dr. Pangatai asked the question if I had any, after I looked at the data, if I had any suggestions. And so here are some things that just quickly jumped out to me as I read through the data. Of course, I don't have all the raw data. And unfortunately, I didn't quite understand all the Thai when she described it all. But a few things that would help me as I look at it probably would help others as they get this data too. The first is, nowhere on the charts did it tell me what size this patient was. So I don't know if if the patients collected for these exams were 70 kilos or 10 kilos, or they may have all just been 20-year-olds. My point here is, we just need to, when you take this data and you now send it out to all the different hospitals, you've established the exams, you've established the technology. Now you just need to establish what is the patient population that hospital should use to collect their data to calculate their median value. So it could be weight, it could be age, it could do physical patient size. However it was collected, that's how they need to do it for their calculation. Obviously, she showed this, and she indicated that the digital systems, the digital radiographic systems in Thailand, produce a dose that is much, much higher than the film screen. Now, interestingly enough, that is a phenomenon that when here in the US, we went digital. It took a while to figure out how to convert a film-based technique chart to a digital-based technique chart. You would think the very first thing you do is you take the film-based technique chart and just simply use the digital. Well, ultimately, digital imaging doesn't obviously require as much radiation dose. And so that's why obviously the dose values tend to be higher. Now, these values are much higher than the film screen. So there wasn't a simple cut and copy and paste. It has to do a lot more with how the images are being acquired. Why is there such a difference in the ratio? The simple answer, without me even being in Thailand, is this. When you acquire an image with film, you immediately know when you've processed that film if you did the right thing. If you used the right technique factor. If you did not, you underexposed or overexposed the image at some level. These are extreme value examples. Obviously, as a radiographer, as a technologist, kind of what to expect, the image quality. And so when you get an image that looks like this, most likely that the radiologist is going to say something. They might ask you to repeat the exam. So you just learned that process. This is a cue that has been given to you as a radiographer. In digital radiography, this cue is gone. You can over and underexpose a patient, and almost always the image will look like the one in the middle. So How do you get past this idea of knowing which image was acquired at the right dose or which one was not? That has to do with using what's called the exposure index. Now, once again, this is a very specific question, a very specific idea that needs to be talked about when we go over radiography. So unfortunately for the next month, we're going to talk in March, we're going to talk CT, but when we come back together in April, we will have the opportunity to really go through DR, and we'll go through it in detail, and we'll talk quite a bit about exposure index. And so hopefully as a group, we can come together. I'm sure you and your Thai medical physicists, your technologists, I'm sure you all already have ideas on how to move forward to adjust this and optimize this, but we will go over that in this seminar and hopefully come up with some good ideas as we continue to investigate this process. All right, so the next thing is the values are obviously skewed. So we know now why, because film tells you when you've overexposed so you can keep your doses low. We know these values are skewed. So it basically says one thing. In general, digital radiography needs to be optimized. It doesn't necessarily say, I mean, obviously chest PA is much higher versus a much higher ratio than, the lateral spine. Excuse me, the L spine, not the lateral spine, the L spine, a lateral L spine. Okay, I know I can speak. I'm sorry. But overall, all of these values are much higher than these values. And so it gives us a good point of place to start. Is this a good thing or a bad thing? It doesn't matter. It's a point of optimization. So we get the investigation team together and we start to go and we just work out this systematically. Let's start with chest PA. It's the highest. Let's go to skull AP, PA. There's the next highest. And then we'll start going down the spine. Now, it would be preferable as we start to gear up for the second cycle, 2021. Thailand was going to go back through and start collecting CAP values for radiography. Well, it would be an ideal situation if the technologists and the medical physicists and the radiologists will have us identified key factors for optimization and implemented those as best as possible. And that will help when you go to collect all new DRL data to get a better picture of what a digital radiographic system should look like. Because remember, this whole third quartile, this DRL, it's a value that's meant to kind of help draw the line in the sand of where optimization should happen. So if all of the data is skewed, that means it's hard to say what needs to be optimized because all of it needs to be optimized. So the goal here is to reduce the extreme high values. There were some very extreme high values. We got to reduce those as best we can. And luckily, you already have data. You kind of know which hospitals are at the extremes and which ones are at the lows. Those that are at the lows, when they get this data, hopefully their investigation team will start to ask the question, are we low on purpose? Is this a good thing? And my guess is probably it's okay. You have all of this data here, and it's wonderful that you have taken the next step. You've collected your local, regional data, you've established your national Thai DRLs, and now you're looking at international values. This gives you perspective. It gives you an understanding of kind of how you as a nation are doing compared to other nations. And it's very important that you do the comparison with like population. So we're doing here, this is the CT data. So we can look at, for example, the trunk, the chest, abdomen, pelvis. That's probably the one region of the body that's going to be the most different from one group of one country to the next. For all intents and purposes, our heads are probably the exact same. My head's probably the same size as most Thai people's, and vice versa here in America. And Japan, Korea, Malaysia, we probably all have the same size head, same size circumference. And our arms, our hands, our extremities. But when it comes to our bellies and our chests, that's where variations on diet and variations on just lifestyle, that changes the most. In America, we probably eat too many hamburgers. And so comparing your values to America may not make as much sense as comparing them to Malaysia or Korea, for example. So doing like comparisons very important. So when you look here at the data, obviously you give the values for the single slice and then what would be probably considered the more modern data, it's greater than 64 slice. And you look at these values. So I'm just going to focus here on the abdomen, just as a point of reference, abdomen, pelvis. And your DRLs are basically 14.8 and 15.7 for non-contrast and contrast. And you can see how, for all intents and purposes, you're kind of right in the middle of the pack. Korea is much lower than everyone. They're the lowest. And then Japan on the other side is the highest. But then compared to Malaysia, Australia, the US, and in Europe or the UK, your values are right in line with that. And so that's a good thing. And so if you're going to establish a DRL, the question is that optimization point a good point to optimize? And so here, looking nationally or internationally, your values are in line with how most people are imaging in the region or in the world. Now, you may have an opportunity to ask yourselves, why is Korea much lower? And hopefully maybe they've published some of their data and then there's some reasonings. Maybe you even can reach out and talk to their Ministry of Public Health. But it doesn't necessarily mean that this is a race. It's not necessarily a beauty pageant per se. You don't necessarily want to be the lowest dose person on the block, or you probably don't want to be the highest, but you don't want to necessarily be the lowest per se. There's always a reason behind these numbers. And the pure fact that you just sit somewhere in the middle of all those numbers is a great thing. That's a great thing. Now, another comment. So here we're looking at digital breast. You guys collected for your various different views, your standard views, and then you did it for the metric of mean glandular dose. So this is great. You've established which exam types or views, and you've established what metric it is. So this is a template that everyone here in Thailand will be able to apply, so they can calculate their median values, and then they can compare it with the national DRL or the 75th percentile. But what happens when all of these values are basically the same, and breast imaging is very unique because the recommended value for every view in a breast image should be less than 3 milligray. In the US, it's by law. It's FDA, our national agency that basically establishes the regulations behind using various different pieces of equipment, one of which, of course, is mammography. They say you can't be higher than 3 milligray, or you can't be accredited, you can't get reimbursed. But in this case, you guys are great. Down the board, you're basically 2 milligray. So how can we now optimize around that? So the question is, Dr. Panrutai talked about the interquartile range, and we talked about it a little earlier today and this morning. So let's look at the interquartile range. Now, remember, interquartile range is simply the difference of the third quartile and the first quartile. So when I did this quick math, you can see the IQR is, for all intents and purposes, the same for all but one view. And so this gives you an ability to look at the spread of your data and ask yourself, are there still outliers? All of these values are below 3 milligray. Your 75th, your DRLs are all below 3 milligray. So that's great. Optimization wise, if your dose is below 3 milligrays, you're doing good. Do we need to optimize more? Well, let's look at the image quality. Is the image quality sufficient? Maybe not. But now if you look at this, the right medial lateral view, it's just a little different than the other. So why is that? The first quartile is just a little higher than all the other first quartiles. And the third quartile is just a hair lower than at least these views. So the question is, why is that? Do these three views, could they be imaged a little less? Or does this view, image quality wise, maybe need a little more dose? And so this is where the team can start looking at the data and start making analysis of, okay, where I should focus. And then, of course, the local hospital, when they collect their data, the first thing they're going to do is they're going to compare it to the 75th percentile. And hopefully, and most likely, all of their values are going to be less than this 3 milligrade range. And so now they can start doing these interquartile calculations and determine, is there still room for some kind of optimization? All right, dental DRLs are unique. Dental is probably the only modality where we're not actually comparing patient dose. And what we're doing is we're managing and achieving optimization based on the application of the x-rays. And so when you saw Dr. Panrutai's data, they calculate it based on various different teeth, various different incisors and molars. And when you go to acquire the image, intraoral image of, let's say, your molars or your incisors, there is a technique factor on the dental x-ray tube. As you just flop it, you just click it onto incisor or molar, and you pull the trigger. And it's the same for basically every patient. There may be some differences between a digital, it depends if you're using a CR plate or a piece of film inside your mouth. So there is a subtle difference in maybe that dose application. But for and there may be a slight difference for kids versus adults. But most dental systems are fixed at 1, maybe 2 kVs, and the MA output is almost always going to be 7 MA. There may be, depending on how old or new the system is, there may be one other MA out there. And so the reality is there's not much to change on this. And so the output, the air kerma, is dependent on just the measurement of the ion chamber on top of, right on the outside of the dental cone or the PID. So not specific to patient dose, but it is specific to the equipment type. Is it a new system, an old system, a digital system? Where it's imaging a digital film, or is it imaging film, just film, or old style radiographic film? And it depends specifically on the tooth. And so these are things where the technologists and the physicists can get together with a dentist, and they can really optimize the doses very quickly and make sure they actually are using one technique factor for one tooth versus another, and they're changing the technique factor for digital versus film. So there is some room for optimization, but for the most part, it's pretty straightforward in dental. So to wrap up, what are some of the futures that are coming that you all are going to you need to expect here in Thailand as you continue to work forward establishing all your national DRLs? The first is your multimodality imaging. Obviously, you've started to acquire scintigraphic imaging. And so you got your technetiums and who knows, your galliums, 67s, and whatever it is that you're acquiring to establish your DRLs. There may be room to start collecting SPECT CT data. So now you got your rotational nukes, and then especially for PET, obviously almost all systems modern systems come with CT. And so you have multimodality imaging. You have to set appropriate DRLs for each modality individually. So even though the PET CT scanner is a PET CT scanner glued together, you need DRLs for them individually. And the same thing for SPECT CT. Now that you've established on your most common examinations for most of these modalities, it's time to start looking at some of your low priorities. And this is where, for example, in fluoroscopy, you can start to ask yourself about general fluoroscopy, that the gen fluoro. This is considered a low priority examination type, mostly because it's very low dose, doing a VCUG, a video swallow, whatever it is that you typically do in Thailand, which are probably consistent with everyone else in the world. but they are almost always much lower doses compared to eventually an interventional procedure. So at low dose, low risk, it's a low priority. And then there's, for example, mobile C-arms and fluoroscopy, oftentimes used in the OR and the surgery suite. These tend to be low priority because they are crazy difficult to get a consensus data, because they're used on everything from orthopedics to just general imaging for surgery. And therefore, they run the gamut. They run the spectrum of types of body parts you're imaging. Therefore, the dose levels are going to be different, and the use factor is much different. And so these are very difficult to come up with. But as a next, second, or third pass, it gives you the chance to start incorporating these in future DRL calculations. And of course, we can go on and on down the list. Obviously, there's extremities for radiographs. There's the face and the orbits for CT, all of which can eventually be added now that you're moving towards an electronic data repository to collect all this data easily and do your calculations. So in conclusion, Thailand has made very strong progress in developing initial DRL values for a variety of imaging tasks. The next steps include applications of the DRL at the local level. So local hospitals now applying the Thai DRL values. Further optimization, we talked about some examples of this. And you are now at that point 4 or 5 years into this for the next cycle to begin. And so to aid in these next steps, we need the distribution, installation of monitoring software that will just make this much easier than continually doing this manually. Software will be used to collect the data for DRL 2.0. It will be used to locally compare median imaging tasks with those publicized for the national DRL. So this helps with the optimization process, the local individual hospital optimization. And we'll talk about this as we go through each modality, but it helps when you have this software to establish alert levels, so that this is the point where a radiologist can start looking at patient-specific examples. So once you have your software installed and you have an adult, a kid, someone go in for their non-contrast brain, and you've set your alert level at, I don't know, let's say 70 milligray, and the value is higher than that, now you're going to get an alert value, and you can say, okay, something isn't right here. There's no reason why this patient should have got 80 or 90 milligray, because we set the threshold for an alert value here, and we expect basically all of our doses to be lower than that. This is independent and different than DRLs, but this is where you can now start to get to patient-specific optimization. And so, sorry about that. We will discuss alert levels and how we establish those as we go through each modality. All right, so we have come down to it, to the end. I know we're really close on time for the whole session, but Tanya, if there's time for questions, I am more than happy to entertain them.
Thank you so much, Sam, for looking in our data and give us some comments. I believe that Panuthai have the number for the patient's weight on each data, but she probably did not put that things on her presentation. Yes. Mm-hmm.
Yeah, and most likely that I knew that would be true, because as you send this information out to the local hospital or put it up on a website, obviously you're going to have the instructions on how to do the comparisons. And so that's just one of those points of value that you'll add to the instructions.
I need to leave a little bit. She just left because she has some like a family stuff to do. So yeah. So to answer my questions that I asked you, how can I integrate that things to individual patient? The answer from you is no, right?
Oh.
No for individual patient, but as a radiologist, you just observe the data from patient to patient, and maybe at the end of the month or end of the 3 months or end of the year, you review those data and maybe adjust those protocol to follow the national DRL.
And so as a radiologist, you are key in helping identify this, because in the examples that I gave, if you are a hospital where your average, your median value is higher than the national DRL, then we need your input to answer the question, what is good image quality? most likely we want to reduce the dose, but how low can we go? And that's why we need your eyes to tell us, okay, this is too low, this is okay. I feel confident in my diagnostic task. But patient to patient, it's hard to say because that's where the variation lies. And so you do need to collect data for several weeks or months, or retrospectively look back at maybe your PAC system and find a couple, 20, 30, 100 patients. And then when you collect all that data, maybe then you would sit down with the radiologist and look at a sample of these. Here's 10, here's 20 of the 100. Is this image quality okay? But we'll go through all of this when we talk about each modality, kind of the approach for optimization and how we can use you, the radiologist, as you are a key team member with the technologist and the medical physicist.
So can you tell us about the process in US, maybe like in your hospital, when you have national DRL and compared to the data in your hospital, what process you have done at the hospital? You have like the quarterly meeting with the radiologist to look on those data, or it's just like a purely physicist job to do that thing?
So it obviously is going to vary. Every hospital probably has their own approach. Not every hospital in the US has medical physicists. And so most likely, most people would look at this annually. In the US, there are certain laws and certain accrediting bodies that require us to do some kind of optimization and review at some periodic frequency. Cincinnati is in the state of Ohio, which is just one state, one province in the US. And it has a law that requires me to do it at a minimum of once a year.
Okay.
Our hospital, we do it quarterly. So every 3 months, we sit down and we review, let's say, the brain. Let's look at contrast and non-contrast. And we ask ourselves, okay, what are the dose values? Okay, here's the dose values. Here's the DRL. All right, we're below the DRL. We know that. Okay, is there anything we need to do to improve the image quality? Almost always, our radiologists think the image qualities look bad. Our numbers are really low. And so there's a chance for us to help improve that so the radiologists can do better, or they can do what they need to do. And so the answer is, depends on the staff. And I know Thailand is very much like this. You don't have as many medical physicists, but you have a lot of technologists and obviously a lot of radiologists. And so you have the opportunity to kind of work as a group. Maybe there's a medical physicist that works in a region and that's able to go around. And with the help of technologists that will collect that data and help analyze it, then you can work still as a team. Although you have to figure out, I can't do this monthly because obviously half of my team is at a different hospital for a while. And so maybe you have to set it up. And this is something each hospital should establish on their own for good practices. But it would also help maybe if the Ministry of Public Health or the OAP, whichever regulatory body maybe has the jurisdiction, maybe they could help define a minimum, maybe once a year, every twice a year. And then that's something that every hospital will just start to do. And the way we do it in the US is it's for very specific protocols, the common protocols: head, chest, abdomen, pelvis, and CT. We do perfusion, just the high dose ones. And so it helps to that's why it helps to have the legislative body help define what probably is the minimum everyone in the country does. And then every other hospital hopefully can do better than the minimum.
I see. That's good to know. Yeah. เดี๋ยวช่วยเปิดไมค์ให้อาจารย์เพชรลีนิดนึงนะคะ There is a question from Dr. เพชรลี จุฬาลงกรณ์ University อาจารย์ถามไหมคะหรืออาจารย์ให้หนูถามให้IT ช่วยเปิดไมค์นิดนึงค่ะให้อาจารย์เพชรลี So the question is from Dr. เพชรลี She is a medical physicist from จุฬาลงกรณ์ University So her question is, do we have to identify the breast thickness for the mammographic dose data collecting? อันนิดนึงค่ะอาจารย์คะอาจารย์ได้ยินไหมคะ So the question from Dr. Petri, she is a medical physicist from Jaipur University. So her question is, do we ไม่ใช่อันนี้อาจารย์ต้องปิดเสียงอันที่อาจารย์ฟังอยู่I cannot hear you, Sam.
Can you hear me now?
I can hear you now.
I have a little button here I keep bumping. Sorry. So the answer is it depends on how the data was originally collected. So to do a mean glandular dose, my guess is Dr. Penrotai did not do thickness or density calculations. There was probably just the machine output. So we assume a normal compression and we assume normal position and we get the mean glandular dose out. So that's just an assumption. If that is how the original Thai DRL data was established, that is how the data should be collected for analysis everywhere else. Now, the question is, now your data was very consistent. It was all basically 2 milligray. And so you probably don't need to do more. But in a different outside of mammography in head or I don't know, chest or abdomen where the doses will spread, instead of doing just abdomen pelvis, eventually, maybe in the future, you'll do abdomen pelvis that is for, I don't know, 20 to 30 centimeters. And then you might do 30 to 50 centimeters. But that's more of anatomy that changes so much. And I know breast density does change, but my guess is the way they acquired the data that they did not make that assumption. So having that for local reasons may be helpful, but I don't think it's that necessary for the national level.
I see. อาจารย์เพชรลีคะตอบคำถามไหมเอ่ยไอทีช่วยเปิดไมค์อาจารย์เพชรลีด้วยนะคะหรือเปิดไมค์ให้ผู้เข้าฟังทุกคนได้เลยอะค่ะ So but I mean the thickness of the breast may affect the dose, right? Because type like our Asian population compared to Western population, the breast thickness, breast size is different. Mm-hmm.
Yep. And so yes, it definitely will. But we're assuming.
Okay, แล้วค่ะอาจารย์ So, but I mean the thickness of the breast may affect the size, right? Because.
But I think what we're doing here is we're assuming compression, normal compression. So, irrespective of how dense or how thick the breast tissue is, if we're using the proper compression, obviously the breast tissue is going to be a little different. And that's why there's going to be a little bit of a variation in dose. Your distribution will be slightly different from a very thin to a larger breast. Does it make that big a difference if we now if we actually make a physical measurement and then we stratify it into 2 or 3? The original data, as you can remember, it was very homogeneous. It was a very tight distribution. And so that means even for thick breast to small breast, it didn't make as big a difference. Now, if you compared your numbers to American women that potentially may have a different size breast, then maybe that size could be part of the calculation. But for what you're doing in Thailand, I would say no, it's probably not that necessary, as long as the machine is working properly and you get good compression. If you get good compression, I think you're good.
Okay, sounds good to me. So thank you so much, Sam. I think we don't have any questions right now, but your lectures give us a good teaching point because after we have announced the Thai DRL, there was an issue that happened that technologists that when they saw that number, that data, and they reduced dose. Right. Immediately, and the I have heard some comments from the radiologist about the image quality that we cannot read. It's like a non-diagnostic image quality. So after that national DRL announcement, so that's why I want to know, like, what should I do to tell my technologists or to improve image quality? And you answer that question very well, that I cannot do individual adjustment. Your answer is no, Tanya. You cannot comment based on one patient or one data.
Yep. But one patient added to another one, after a week, after a month, you will have enough data. And that's a good statistical sampling. And hopefully then the numbers will help you make a good decision.
Well, thank you so much, Sam, for giving us an overview. And we will see you. So next week is a break.